All right, it's 5:30. Hello, everybody out in Zoom land. As you can see, I'm here with my colleague, Dr. David Lee, to do this PSPS and Reactivate webinar. I am a neurosurgeon here at UC Irvine. I'm also the president of PSPS for this year. We're going to be doing this innovative webinar here where we can do some of the didactics and lead into our on-site training at the PSPS annual event in meeting in Newport on October 2nd, 3rd to 5th. We're just going to go right ahead, get started with Dr. Lee will introduce himself when he gets onto his section. We're going to be talking about neuro restorative stimulation. I'm going to start off with talk about trying to understand the role of neuromuscular control in these non-specific or chronic low back pain patients. Dr. Lee will take over, go over the emerging evidence of Reactivate. I'll go over the randomized controlled trials, and then we'll go over some of the diagnostic testing that's necessary to really sort out this bucket that we've traditionally called non-specific back pain to more specific categories. And then we'll go over some real-world case studies that were in the randomized controlled trials. At any time, we do have a chat function. You can go ahead and send your questions in. In between the different sections, we'll take stop and pause to take some questions as well. So here's the first session. This is about the understanding role of neuromuscular control. This is something that we in spine surgeons, we understand this. This is based on work by Punjabi and White long time ago, talking about the neuromuscular control. A lot of times we focus just on radiographic findings, but really there is the neural control mechanisms, there's the structural components, and then there's the muscle surrounding all the structure. So it really is a triad that defines whether we have stable backs, and if we don't have a stable back, then we have low back pain. For a spine surgeon, I see all of these four different kind of patients. Over here in this 27-year-old male with 8 years of back pain, this patient has, preserved discs at every level. Nothing's wrong, no stenosis, but just a black disc here, some loss of disc height. Now, this is generally a 27-year-old. We certainly wouldn't consider fusion. There's not great evidence for artificial disc replacement. Every once in a while, you might get a candidate for that. But in general, even if you do an artificial disc replacement for this, trying to cure this radiographic problem, you might not be addressing the underlying cause. So that's why I think that our webinar tonight is really important. It's going to change how we think about patients with back pain, how we incorporate radiology into that, and how we think of this, again, as this neuromuscular control of our backs and when that fails. The second case here, a 41-year-old female, she's got 20 years of back pain, again, significant degenerative disc disease. And this one also has some modic type end plate changes. So there are other therapies that really target modic changes and do nerve ablations of the basivertebral nerve. So certainly that's an option for a 41-year-old woman. But again, does that really address the core problem, or is it just blocking the pain signals and allowing things to deteriorate further? So I think that if we can come up with a restorative treatment, it would make sense in this scenario as well. Some surgeons would look at this and say, well, she's a female. She doesn't have risk of retrograde ejaculation. She doesn't look very overweight, so you can get in there pretty quickly with if you have a good access surgeon, get in there with an ALIF and do a standalone ALIF cage and fusion. Again, these are things that aren't well illustrated in our literature. There's certainly a lot of people that are doing those type of procedures. But again, both of those have much higher risk than the kind of restorative stimulation that we're talking about today. So although I'm not going to bash other spine surgeons that might consider doing an artificial disc in this young man or doing an ALIF fusion in this almost starting middle-aged woman. I would certainly push up in the algorithm the option of neurostimulation. Now, this patient here, most spine surgeons wouldn't touch this one. There's so many levels of degenerative disc disease, a little spondylolisthesis here. And really, if they have no leg pain, it's all back pain, what are you going to treat? Are you going to do a 4-level interbody fusion? Are you going to do a T10 to pelvis? You know, I'm sure it's being done somewhere, but that would be pretty crazy, and by most surgeons' opinions. So for a non-specific back pain, that would be way too much. But this person might be a good candidate if they meet the criteria for a neurorestorative stimulation option. Here's a patient, 32-year-old. Again, as a spine surgeon, you see a slip and you think, okay, they're going to need a fusion. But the literature is backing up the idea now more than ever that if you have a stable spondylolisthesis, and by stable, I mean not just on flexion extension. So sometimes they have so much pain that even with flexion extension, you don't see much abnormal movement. What you want to do is compare a supine MRI or CT scan to an upright X-ray and see if any of the upright X-rays, flexion extension, neutral, changes compared to that. If there is dynamic instability, there's a mechanical reason for that back pain, and no matter what benefit they might get from stimulation for a while, we know that that instability is going to override that eventually. We know that from the spinal cord stimulation data and experience as well. So if this is a stable spondylolisthesis, it's not really a surgical candidate for predominantly back pain. Now, if this person had back and leg pain predominant especially, and you're going to be blowing off those joints, and so you're going to cause more instability here where they already have a stable slip. You're going to create an unstable slip. Then a TLIF or just a posterolateral fusion might make sense. But certainly if it's a stable spondylolisthesis, we don't have much to offer this patient as a spine surgeon. So I wouldn't really call this a dilemma. These are just the routine things we see in our clinics every day. So how do we treat these patients? Well, as surgeons, we haven't been doing a very good job. We don't talk to them about reestablishing their core, working on their posture. We might send them to a pain physician and then just write it off, or send them to PM&R and let them deal with it. But we don't usually go into too much discussion about what it means to have a solid core. And when we talk about core, a lot of people think about the superficial system here, the six-pack abs. It's the muscle group that you see that's externally visible. It's under voluntary control. And these are usually fast twitch fibers applied over a large region using useful for high load task. But there is a deeper set of core muscles, and multifidi muscles are part of that deep core muscle, along with the erector spinae muscles. These are largely involuntary, especially the multifidi muscles. These are very important in terms of just maintaining balance. And as this picture shows, when you're brushing your teeth and leaning in a little bit, all of these muscles are activated, trying to maintain that cone of stability in your low back. So these muscles have a high number of proprioceptive cells, these muscle spindles, in order to give the spinal cord and brain the idea of where you are in space with your spine. And it provides this intersegmental support for proper loading. So again, we're going to focus a lot on the multifidi muscles because these are really primary stabilizers of the lumbar spine. Again, involuntary mostly, proprioceptive, lots of proprioceptive inputs, and automatically maintain stability of the normal spine. When this group of muscles are deconditioned or they are inhibited, then we have problems with functional instability of the low back. There are plenty of articles that at the PhD level that that have demonstrated that dysfunction of this multifidi muscle is strongly associated with low back pain. So what usually happens is it's sort of a cycle. Sometimes there is a trigger, but sometimes you don't know where you are and how you started with back pain, and you just got into this circle or the cycle of loss of neuromuscular control. If there was a triggering event, it could be something where you injured a joint, for example. And we know this in, at least my orthopedic colleagues know this a lot more. So if you injure your elbow joint or your wrist joint, for example, you first get that you trigger, you get that noxious insult. It alerts the sensory motor feedbacks to the spinal interneurons. And what it does is it really inhibits the muscles around it. So there's a loop that goes, it doesn't even have to go to the brain. It goes to this interneurons in the spinal cord, and it automatically inhibits the muscles around that joint. And it makes sense because if you have a joint that's injured, you don't want those muscles easily activated around that joint. So this is called arthrogenic inhibition. We know that this is a real thing that happens in larger joints. It certainly doesn't make sense that it wouldn't happen in all of the paired lumbar joints. So as you get this muscle inhibition, if it's for a brief injury, it makes sense. You know, you did something wrong on a basketball court, or you threw the ball too hard. It inhibits those muscles. But if this is chronic, then you start developing multifidus dysfunction. You can start seeing structural changes, probably see functional changes first, and then you start seeing some of the structural changes like the infiltration, some atrophy, infiltration of fatty tissue into the muscles. And that's and then with that comes some functional spinal instability. Remember, we were talking about spinal instability in terms of abnormal movement on imaging studies. Though that's gross spinal instability, but there is functional spinal instability as well, and that happens when these multifidi muscles aren't are in dysfunction and aren't able to do what they normally do, which again is that give that involuntary control of balance to that lumbar spine. So as this goes on, we also see neuroplasticity. Most of you out there are pain physicians, and you know that that's also a real thing that happens. That's one of the reasons why spinal cord stimulation works. It's not just all taking place at the dorsal columns. It is also changing the organization in the cortical areas in the brain. So this is where, again, I talked about those 4 cases at the beginning. The reason why a restorative solution should be placed further up on the algorithm is because it focuses on the rehabilitation, it reactivates muscle control, it reduces pain by addressing the root cause. So it breaks that cycle of inhibition so that we can restore balance to that functional spine unit. Some of these other treatments, certainly things like injections, RFAs, are really palliative. They're just trying to block the pain signals. Spinal cord stimulators might be doing a little bit more than palliation, but that's a whole different topic. But really, in terms of restorative therapies, this is something that's hasn't been available for any of us, whether pain or spine surgeons. Really, we haven't had this option until this treatment has come around. So if you haven't seen this already, this is basically what it looks like at the end of the procedure. You have 2 leads that are placed over the medial branch bundles at the transverse process of L3. So they're coming out, and the branch bundles are right here, right next to the facet and the transverse process. So you do this through just you have to make an incision in the back. You have to, under fluoroscopy, get these electrodes in the right place, make your tension relief loop, and tunnel it. And you can see how they have these nice anchoring device so that it doesn't migrate, because that would be my first question also. How do you keep that from moving? And this is something that really has decreased the risk of migration. So the benefits of these, including these are kind of similar implant techniques that we do. These are anatomic targets that are easy to find, and really everything is outside of the canal. So the risks are very low with this. And the patients tolerate these sessions very well. Unlike some stimulators, this one only requires 2 30-minute sessions per day. So they usually tolerate that very well. They do it when they can lay down on their side or stomach and take 30 minutes twice a day. So, and of course, the generators have monitors in them so that we can check for compliance as well. You know, I know there's this common argument I get all the time that, well, it can't hurt and it's pretty easy and it's just in soft tissue. Why not try this first? And I've always hated that argument. I really have, because there's no science behind it. There's no studies behind it, or very, very little science. The people that usually make that kind of argument, they have some white papers and it's really just an industry push for something. But I've got to hand it to these guys. They have studies. They've done their ID studies. They've done 5-year outcome studies. They have real world experience. And as someone that has no financial ties to Mainstay, this company, really the only conflict I have is that they supported UCI doing a Mainstay teaching event. I have no reason to push treatment that really would potentially take business away from me, right? So I think that this is something that really can serve our patients. And so I'm excited about presenting some of this data to you tonight. I'm going to talk about some of this data as well. So you can, I think all these references will be provided to you guys, but you can see that there are multiple studies. One of the things I like about the evidence that Mainstay has provided here is that certainly there's pain journals, and that's where they publish some of the first IDE studies. But the longer term outcomes they published in mostly in neuromodulation, which is a multidisciplinary journal. And they published in a couple spine surgery journals. So it's unusual to have that kind of broad publication record, PM&R journals as well. So this has been something that's peer reviewed and vetted through several different societies and certainly different disciplines. Dr. Lee, I'm going to hand this over to you to talk about some of the emerging evidence.
Yeah, thank you, Dr. O. Appreciate that. Dr. O did a phenomenal job of kind of covering the kind of introducing the therapy to y'all, and I appreciate that. This kind of segues very nicely into my first section here, which I'll be talking about some emerging evidence of the restorative nature of Reactiv8. Before I do that, I do want to briefly introduce myself. Many on the call, I believe you guys, we've met, we've interacted. I know a lot of interventional pain specialists on the call tonight. I'm an interventional pain specialist located in Orange, California, and practicing now alongside Dr. O. Feel very fortunate to be able to call him my colleague now at University of California, Irvine. My background's in physical medicine rehab. That's really how I got to the working with Reactiv8 and Mainstay. Is I knew that this was a therapy that was restorative, and when it first came out, that was for me very compelling. As Dr. O kind of alluded to, majority of the things that we do as clinicians, particularly in pain management, is palliative in nature, and so we're either blocking it or we're, stimulating it to reduce afferent pain signals that are traveling to the brain and being processed in the cortex. One of the things that I give much credit to Mainstay for doing, and kind of Mike alluded to this very, kind of in ways, is that they've done an amazing job of publishing things on a consistent cadence. So if you look at that previous slide that Dr. O had up, let's see here, oops, no control here now. You can see just the breadth of amount of publications that are out there, and it started off with their IDE study, as Dr. O was alluding to, their explanatory randomized control trial, which was Reactiv8B, and fortunately has been extended out now to 5 years. So one of the criticisms within neuromodulation is always that you stimulate something palliatively, you get some pain relief, but then there's a tolerance that builds up to neurostimulation. And Dr. O has familiarity with this from implanting paddles, and I do both trials and percutaneous implantations. And so, we've historically seen this. This has gotten better, of course, with novel waveforms, but still remains very problematic when you're talking about trying to treat patients for the rest of their lives, right, with neurostimulation, because usually that comes kind of later in the treatment algorithm. Additionally, they kind of follow that up nicely with real world studies. One of their works that's presently ongoing is the RESTORE study, which is a pragmatic trial that compares the Reactiv8 therapy to conventional medical management. Many therapies that are out there presently, that's kind of like the next big step, right, for adoption, wider adoption, and also they know, and it's just as important these days, is insurance coverage and authorization. I feel very humbled to be part of one of their papers that was kind of a clinical guideline or guidance, rather, for clinicians and for colleagues, and that was a restorative neurostimulation, a clinical guide for therapy adoption, which is also available. But one of the things that was kind of always missing was, and this was kind of recognized by a lot of the initial adopters, commercial adopters, as well as those that were part of the initial Reactiv8B study, was really trying to make a case for this mechanism of action, right, that Dr. O was talking about, where you're reversing arthrogenic inhibition and you're creating restorative change in the actual anatomy of the lumbar spine, right? Because the biggest question here has always been, and obviously critics rightfully have suggested, is what really separates this, 2-session, 30-minute stimulation a day therapy from palliative peripheral nerve stimulation, PNS. Well, it's always been this restorative mechanism of action, and it was not until recently then that we had something to kind of really hang our hat on here. So I'm going to be talking about this specific study, which was recently published in the European Spine Journal by James et al. I will give a little tip of my hat to Dr. Ben Goss, who was a part of this study and listed as one of the authors. He also has been always a champion of really pushing the idea of publications and further studies in this regard. So just a little background here. So I would encourage everybody to read this. It's not a lengthy paper, but that thought here was that for a long time, when we stimulate the muscle, the idea is the muscle grows larger, it hypertrophies. Well, us in retrospect and looking back at a lot of these patients, we very quickly realized that that's not really what's happening. And I think the expectation of a hypertrophied multifidus muscle isn't realistic anyway, because we're only stimulating it in a very natural fashion, right? Not aggressively for 30 minutes at a time for twice a day. So the idea is not necessarily hypertrophy, it's toning the muscle and trying to reconnect the muscle itself to the central nervous system, activation. Just some little background here, particularly for this study. So fibrosis is a consequence of multifidus degeneration and impacts function of multifidus muscle. A lot of this is inherently pretty obvious. In the model of intravertebral disc degeneration, connective tissue usually accumulates in the multifidi, right? This makes sense. When people have injured discs, it tends to affect their functionality. That's kind of an insult that Dr. O was initially talking about, and then that leads to a cascading of debility guarding arthrogenic inhibition. Aerobic exercise has been shown partially to reduce the fibrotic changes in multifidi. This particular study, the intention was to investigate whether activation of the multifidi muscle could reduce fibrosis in the actual muscle itself. And they used a sheep model to perform this study. So they essentially took 18 sheep, which were randomized into 2 separate groups. All of the sheep were given unilateral annulus fibrosis lesions at L1, 2, 3, 4. Restorative stimulation was implanted at L2, and the device at that time after that was not activated. But then allocated in 2 groups. One was a control group obviously no activation, no stimulation. Device activation was then similar to that of what's delivered in humans now. And then eventually the sheep were harvested after a 3-month period, and they looked at histological samples and immunological samples of the actual muscle tissue itself. And so what they found was pretty compelling here. So when they looked at stimulation versus non-stimulation, so sorry, it's non-stimulations on the left, and that's kind of essentially the control, stimulation being on the right. First of all, face validity, they saw dramatic differences in the actual muscle, gross muscle look at itself on a histological slide. But then they took it a step further, and they actually looked at the fibrosis and the collagen that's expressed within the muscle itself. And if you look, these are pretty simple pictures here, but if you look at the red striations on the pictures in the middle here, you can see there's quite a bit more on the left-hand side than on the right-hand side. And when they did immunohistological staining to those muscles, it showed actually less collagen expression on the one group that had stimulation. So this is just kind of early fundamental work that needs to be done to really show that there's actually anatomical changes that are being provoked. But what this, essentially kind of is moving towards is that multifidus muscle activation can prevent and restore structural changes. It can also restore optimal muscle activation and also reduce muscle immune response. While general exercise is beneficial, we understand this, we know this. One of the talking points always in regards to, why this treatment, if not, if other than just physical therapy, is that we know that the multifidi muscle are deep. We know that they're involuntary. We know, as Dr. O was saying, that very difficult to activate, unlike a lot of superficial muscles that surround the core, like the rectus abdominis, the transverse abdominis muscles, the lats. So even with a person who's very active and able to do physical therapy as compliant, they may still have essentially a weak multifidi muscle or dysfunctional multifidus muscle. This is where restorative neurostimulation really comes into play. Turn things back over to Dr. O here.
All right, I forgot that we promised that we were going to pause a little bit to allow people to ask some questions.
Yeah, no questions yet. Yes, Dr. O, thank you for reminding us. So there were a few people that joined the call late. So there is a Q&A tab in Zoom. So if you have questions as we move along through each of these sections, please feel free to do so. Dr. O and I will periodically check the Q&A box there and answer any questions that might come up. Thanks, Dr. O.
So we're going to talk a little bit about the pivotal trial here and some of the real world evidence that followed as well. So this is recently published. It's a 5-year follow-up on mechanical chronic low back pain. This is again, kudos to them. It's a unique long-term study. We usually don't see this in simulation. We see this pretty regularly in terms of fusion studies. So I think that having something like this really supports. If you're going to try to say that this is something that you should do before fusion or artificial disc, then I think you're going to have to match the data at 5 years at least. So that's what they've been doing. This is 204 participants that were randomized. It's a kind of sham controlled. It is double blinded, meaning that there were 2 arms, one that got the active stimulation and one arm that got a sham stimulation, which was at the lowest settings. But it's possible that they could have felt some differences and suspected things. So, but there's really, it's still a well-designed study. It's hard. It's going to be hard to do anything where there's, randomized, the patients are completely blind. That's one of the questions I've always asked Nevro. If you have a paresthesia-free stimulator, why don't we have that randomized controlled study? But with this one, you do feel the stimulation because you do feel contractions of the muscles. But they did the best they could to randomize them sham control. They were double blinded, and then there was a crossover design. 62% went on to complete analysis at 5 years in order to make up for that. And that's not atypical. Even with fusion studies, we get maybe 75% at 5 years. There's always going to be drop off. People move, people uh, just stop using it, or people get better. So there's lots of different reasons why they might drop out. But they were all analyzed in the intent to treat model that accounted for all 100% of the patients. They use this thing called a mixed model of repeated measure imputation. It simply means that if you dropped out at some point in the study, it takes the group, kind of the results that you were having, and just continues them on to the 5 years. And you'll see that by doing that, they make their numbers a little bit worse than, and so they did an honest job of presenting that data. Certainly, if you just look at the device, you know that unless it short circuits or explodes, it's going to be pretty safe and durable. These stimulators have been implanted in lots of people for long periods of time, so I wasn't suspecting any problems with safety, durability, but certainly effectiveness is what I want to focus on. So these are of the 204 patients. What do they look like? They look like this box here. They had a baseline pain level of 7.3, baseline ODI of 39. So it puts them into this right here in the moderate to severe group for ODI, and right there in the moderate to severe group for low back pain. So this is a large number of patients that we see in our practices. It's not just this group at the very severe end, right? And then, so these are the patients. All of them had to have had physical therapy, failed conservative treatments. All of them had something called a prone instability test. That's going to be something that is explained later on in the actual. It's something you have to see that, as well as the multifidus lift test. Something you have to see during the actual demonstrations. But this is one of the reasons why I liked this study, even as a spine surgeon that wants to do fusions and artificial discs. I like this one because it took all of these non-specific back pain patients that I was seeing, and it allowed me to do a provocative test. It reminded me very much of when I was convinced that SI joint pain was a real thing, because I was able to do provocative maneuvers there as well. Just like SI joint and SI joint fusion, in order to get the right patients for that, the provocative maneuvers are actually more important than the imaging findings. So there are a lot of imaging findings that you might see, and you saw on the beginning. We gave 4 cases of very different imaging, but I think this fact is really important, that all of them had some sort of provocative maneuver. Either the 100% had the prone instability test, and most of them also had a positive multifidus lift test. So the things you have to exclude, those prior low back surgery. Right now, some people are investigating that as well, or surgical indications. And this one, again, is something that it's really important to work with a spine surgeon. So if you're a pain physician and you're going to do this, it's got to be something you discuss with your spine surgeon, or otherwise that referral, back and forth referral relationship can be lost pretty quickly. I think that if a spine surgeon is presented with all this data, I can't see one in good conscience not saying, oh, I think the evidence is real, let's go ahead and try that. So you got to think that, but you know that indications for spine surgeries varies by every surgeon. So that's why this one has to be really taken into consideration. And also leg pain greater than back pain. So this is not for neurogenic claudication. This is not for lumbar radiculopathy. If that is their predominant complaint, if they have even a small amount of that, it's 40% of their pain, 30% of the pain, I would be worried about putting in a stimulator only. You might consider it combined with something else, but that would be a concern. So again, the imaging is very, in this study, they saw grade 3 or higher disc degeneration. A lot of patients had grade 2 or higher facet arthropathy. A lot of them had disc bulges grade 2 or higher. And again, you can see motor changes in 30% of the patients in the study. 18%. So this comes down less. Retrolisthesis, that was about 18% smaller percent of patients, because if there's any kind of instability, they weren't a candidate. And of course, if they have anything other than mild scoliosis, you probably want to have them seen by a deformity surgeon before you even consider this neurostimulation. Maybe something in the future, maybe if this could be used early on in adult degenerative scoliosis, and you can reactivate specific groups of muscles, then maybe they wouldn't progress as fast. We don't know yet, but currently, these are the things that we don't see as much of in that study. So if you have patients with spondylolisthesis, I would take a step back a little bit and make sure it's stable. If they have degenerative scoliosis, make sure it's really mild, because they just weren't studied that much in the study. But as you can see with all these other things, the disc degeneration, disc bulges, motor changes, they were all in the study. So here's the results of 5 years. This is a lot of work and millions of dollars to get to this point. Here, they had their surgery. There was the sham group here, and then they started to go back towards baseline scores in their VAS, but they crossed them over at 120 days. If they had extended this out a little bit longer, that would be only my one criticism. Then we would have seen this curve maybe go up a little more convincing, and then it drops back down through crossover. Nevertheless, to prospectively follow patients for 5 years and get this kind of result, we can see that this is something that over 5 years, we have patients that their VAS scores significantly improved. And we'll go over the actual amount of improvement later on. But this is something that we also see in other kind of stimulation. As a functional surgeon, I do deep brain stimulation, and we see these kind of effects in depression as well. It's not something that just clicks on automatically, and it actually is something that gets better over time. We see that with vagal nerve stimulation for epilepsy as well too, that the initial response may be around the 50% rate, but then it improves out to 2-3 years and gets better, and then it just stabilizes, and you don't see much of a rebound there. So I was really impressed with that data. Here's what I was talking about, this mixed MMRM. If you look at that and you account for all the people that were lost, the results seem a little bit worse than if you count only the people left in the study. So if you look at ODI, they started at around 40. They came down to 16. But if you include the ones and projected the ones that were lost to follow up to what they probably would have ended up, then you can see that it's 39 down to 20. That's a very significant drop, though. Usually we consider that clinically significant when there's a 20 point drop in the ODI. Same thing with the visual analog score. We went from 7.3 down to 3.3, and anything more than 2.5 score difference, we identify those things as clinically meaningful. So if you combine clinically meaningful, and then add to that the healthcare related quality of life that goes from 0.58 to 0.76, I think we have a winner here. At least for 5 years. At least for 5 years, at least gets me thinking of doing this instead of offering them anything that's surgical. Opioid use, same thing. It goes. There was about 36% of patients that were on opioids, and then by the end of 3 years or so, it's about half of those that were on opioids discontinued. There were others that reduced, but reduction of opioids is such a hard thing. They decreased it by 10%. I'm not sure if that's that meaningful, but if they stop using it completely, that's a big deal. And if you could get about half the people to stop completely, that's a win for all of us as well, and society. So here's the summary slide. And remember, I showed you this at the beginning. They start here, they end up in this corner, going from 7.3 to about 2.4, 39 to 16. So those are real numbers that, obviously these studies are all done with some conflicts. They're industry sponsored, but that's the nature. There's no way these can be done otherwise. So I can't criticize them for being industry sponsored. That's that's how all of these are done anyway. I think registries in the future will give us more information. I think uh, having someone like me that's not conflicted, uh, advocating for a procedure like this says something as well. And just reviewing the literature that indicates the 5-year results that show that age, one of the things I would be concerned about is that if we have more elderly patients, in the 60 to 70-year range, maybe this wouldn't work for them because they don't have the neuroplasticity, they don't have the way to reactivate those muscles, but at least when they pull out that group of patients, they do almost as well as the cohort in general. So I don't think that age is a real factor. In fact, it might be a bonus because those are the patients that are less amenable to any kind of surgical intervention and certainly at higher risk for anything that would involve decompression or instrumentation, right? So we have outcomes that are in the clinical trials, and then we have some real world studies. These are all provided in the references. And as with every study like this, you get the IDE study and you get results like this, and then real world studies are not going to be quite as good, but you see the general trend that there is significant improvements in their quality of life, in their VAS and ODI. It follows almost the same track, and it's always going to be a little less because of how selective these IDE studies are. So once you start letting in some people that don't quite fit, then you're going to have this drop. You're going to have this drop. But that's why I always emphasize that when you're starting a new treatment like this, you've got to stay as close to the initial indications as possible, because you want to start with that kind of outcome, right? You don't want to start this and include patients that have had previous surgery, for example, so lumbar fusion or lumbar laminectomy, and you think that, oh, okay, well, it's not very invasive. We can just drop one of these in and see if they get better. So again, just not the way I think, not the way I think you would want to try to start this treatment. So with that said, I'm going to hand this back to Dr. Lee.
Yeah, thank you. I'll just interject real quick here, Mike, on a point that you brought up, or Dr. O brought up, is that kind of age is not a factor. It is kind of an imperative one, important one, especially as of late. When they first did the Reactiv8 study, a lot of the patient population was on the younger side. And so when I was talking to colleagues about this, pain specialists like yourselves on the call today and surgeons, there, the criticism was, well, maybe it's just for young people, and to Mike's point, like it's actually, in fact, the elderly population, which probably needs this the most, because most of the time they're not good surgical candidates. They got a lot of comorbidities. Interestingly enough, while this Reactiv8 study was taking place in the United States, all the way across the pond, involving international colleagues in Australia, they're in Germany, and they were doing these cases in elderly population, and collecting similar data, right? And there was no communication between the United States and the international community at that point in time. And what they found was, when they plotted these data points, similar to what Mike showed, that the improvements in VAS, ODIs in functionality, EQ5D, was that those curves were, again, similarly in terms identical in their improvements. And so it's just interesting to kind of take that then and bringing it back full circle to the United States, where up until recently, Noridian was denying the use of Reactiv8. And their rationale was quite simple: as well, this is a peripheral nerve stimulation system or spinal cord stimulation system, and it requires certain types of boxes to be checked. And one of those, of course, was a trial. And the argument always against that was, well, how do you trial a system that is, as Dr. O showed, restorative in nature, right? When it takes time to get to a clinically meaningful point with all of these patient-reported outcomes. So that was a huge ongoing fight, and thankfully, Noridian came back as of this year and did something quite compelling. They actually singled out Reactiv8 as a therapy and said, okay, well, if you use this specific diagnostic code, which is I have pulled up here. It's actually titled muscle weight. This is directly from the CMS site. Muscle wasting and atrophy, not elsewhere classified back lumbosacral, and that's M62.5A as an apple 2. And you put the codes that are for both leads and the IPG implantation, that it will absolutely be covered by Noridian, which is an amazing thing, because usually they're not singling out certain specific therapies. I'm happy about this because we're in a state where Noridian, they basically control everything that Medicare does. A lot of larger states like New York and elsewhere as well. So it's a huge win for the elderly population who, interestingly, until a few months ago, indiscriminately were being, given the therapy if you were in a state that didn't have Noridian overlooking Medicare, and then not being given it if Noridian was, monitoring Medicare patients. So that's a huge change. I'm going to kind of go into more. Yeah.
Can we pause? And it looks like there's 8
questions.
Oh, yeah,
I'm sorry. Yes. Thank you, Mike, for reminding me. So you want to take some of the lead on some of these questions, or should I just read them?
I'll ask him to you. So Robert Lugo asks, how long are the leads IPG typically kept in place?
Yeah, so that's an easy one, Dr. Lugo. This implantation system is intended to be permanent. And I never sell it as a temporary fix to a chronic pain solution, but it will, since we're talking about it, there was, and I'll mention it from the Reactiv8B study, patients who were explanted due to pain reduction, right? So not failures like we're used to typically with spinal cord stimulation explants, but in fact successes where patients felt they got to a point that they didn't think that they needed the therapy any longer. I see the other one here, Mike, I have pulled up. Is MRI compatible? And that's new. It is full body 1.5 Tesla MRI compatible as of this year. Some really good questions here, so please keep them coming. Dr. Russ states, what time frame does it take for cortical reorganization if stimulation is only done for 1 hour daily? And I can honestly say that this study is probably underway at this point, but that we don't have any actual publications to delineate what that time frame actually is. What we do have is that plotted diagram which shows how long generally it takes for patients to show some substantial reduction of pain symptoms, which is another question from Dr. Abbasi. And it's that
I usually tell them 3 months.
Yeah, so about 3 months. And that's kind of what I tell my patients too. I mean, it can, anecdotally in my experience, be up to a year, and that's kind of along the lines of any type of, larger surgical procedure, decompressive procedure. And I coach the patient, early on in that process is just to, that patience is paramount, right? Because this is, again, a restorative treatment. I always tell people it took you 10, 15 years to get to this point where you're deconditioned and you're having this chronic back pain symptom. Just, give it a fraction of that time back to the therapy to see if this is actually going to work for you or not. And so I have had myself patients where, really at the 12-month mark was when they hit their stride. What we're kind of doing now is we're trying to tease out from the patients that have been implanted within the continental United States is what deems like an early responder, what deems like a kind of like a typical responder and a late responder. And that's going to be retrospective analysis that's going to be done, and hopefully will give us insights as to who the best candidates for these therapies are.
I like this next question about medial branch blocks and RFAs, and should we continue to do those if we're just burning the nerve that goes to the multifid eye? So I've always been wary about this. I rarely send young people for RFAs for MBB RFAs, exactly because of this reason. I know, there's something called Charcot joint in diabetes. When you denervate a joint, that you have all these problems, that hypertrophy of the joint, pain. So I'm not sure why we would do so much of that in young people. So I agree with this kind of question where it's leading. And I think with this therapy that's available, it might change how much RFAs we're doing.
Yeah, I think that's fair. There's been studies that to show that there really isn't substantial muscle atrophy following, radiofrequency neurotomy or ablation to the medial branches. But on face validity, I could totally understand why the concern would be there, because we are denervating a nerve that, yes, innervates the multifidi and the facet joint simultaneously. So is it reasonable to then think, kind of face validity, that then we're hypothetically damaging the structural integrity of the surrounding area while going for the palliative means of treating facet joint pain or arthritic type of spondylosis type of pain symptoms? I think that's the case.
But we know that nerves grow back, right? So
They can, yeah.
How long would you wait after an RFA before considering?
Yeah, I saw that. I think the right now the typical recommendation is at least 3 months, but if you're concerned, 6. The rationale behind that is just more precautionary, making sure that you have reinnervation of the multifidi, of course. But Mike, you may understand this already, but most of the time, as interventionalists, we are ablating L3, L4, and L5. And so, obviously the target being there, we want to be sensitive to that. So if you give yourself, I think 6 months is probably more realistic. Then you're going to be able to sustain a contraction when you perioperative test once these leads are placed. If you don't wait long enough, then you're going to get suboptimal contraction for sure. One of the things, the only thing I was going to say to that Mike point is that these days, my typical algorithm is I still medial branch block patients diagnostically, just to see if they have a large component of facet mediated pain. And if they get, again, 80, the bar is high now because it went from 50 to 75, 80 now percent. So if they get 2 concordant diagnostic blocks of 80%, then you have a real reasonable case of doing an ablation procedure. But even if they do, I give them the choice now, to Dr. O's point of like, well, we can ablate this nerve, or we can, restore the muscles surrounding this area in a long-term fashion. So patients have to understand when you're having this discussion that they're likely going to need a repeat ablation, and that kind of sequence of interventional procedures, unfortunately, rarely stops. Right? You're going to start seeing them sometimes even more consistently, because they're going to be like coming back and saying, well, it's not lasting as long, this is failing. So really, really great questions. Dr. Lu, you have some other questions. I'm going to kind of go over that here just momentarily. Let's see. Dr. Paris, in addition to being restorative, can Reactiv8 also be palliative for patients with facet arthropathy at lower lumbar levels, since it's implanted around the medial branches? Yeah, I mean, there are companies that are actually starting to do this, right, as we speak. When patients, there was a question earlier that says, when do patients notice pain relief? And if you look at what Dr. O's diagram showed, is that even at before the crossover at 120 days, but even after like the 3-month period, the bar was dropping, right? The line was dropping. So I mean, personally, I try to rationalize everything that I'm looking at. I do think that early on in the stimulation process, there is probably some afferent gate control mechanism of action at play, right? That's stimulating. Patients tell me like they like feeling the contraction of the muscle. They like feeling the kind of buzzing sensation. It's not like a really like super strong aggressive contraction that we see typically when right before we do an ablation, right? When we test the placement of the needle. So I do think that there is a palliative aspect of it initially, but if that was the only thing at play, patients wouldn't continue to get better, right? So the restorative nature, and then we saw in the study that I presented earlier that you wouldn't get actual physical changes within the muscle anatomy itself, and that's really what separates palliative PNS in regards to reactivative restorative PNS. I'm going to talk about some of the prone instability, and so any BMI limitation. Only thing I could comment on that, and thankfully we live in the state of California, is we don't have that much of an issue. But BMI issues can also become a problem when you're examining the patient. So it can be very difficult to elicit a positive PIT test. It can be very difficult to elicit a multifidus lift test, which I'm about to go under right now. But I don't, off the top of my head, know if there's actually significant BMI limitation as far as implantation goes. And I answered the last question there. How is this different from PNS? And they put and specifically SPR. So SPR is a palliative temporary system, which is used gait control theory versus a restorative mechanism of action. So I think we answered most of these questions, guys. I'm gonna dive into this section real quick, and please keep the questions coming. That'd be great. I'm gonna kind of clear some of these out here so that we can prepare for more questions coming in here, Mike. And we're gonna kind of switch gears here. We're gonna go into more of a pragmatic talk about like how to, this is a lot from the paper that I wrote. I was part of like, how do you, utilize this therapy in practice? How do you patient identify? And so that's what I'm gonna kind of go over now. So one of the questions Dr. Lugo asked, so if there is any radicular component or more leg than back pain, my immediate algorithm is not to utilize this therapy. Then you're thinking of some other kind of radiculopathic, neuropathic pain component versus a nociceptive mechanical source of pain. And it's not going to work. It's not going to be successful. You see this in practice sometimes, unfortunately, people doing medial branch blocks and RFAs on patients with radicular symptoms, and you're like, well, okay. I mean, suppose you have hypertrophy facet joints, but that's not going to do anything for your lower extremity pain, and it's going to be an absolute reason why this would be denied by an insurance company. So there's a few relatively straightforward ways of getting from kind of looking at the patient to getting them to the particular therapy. And this is really the algorithm that I've integrated into my own practice. So even though we're talking about, multifidus dysfunction, it really starts at the basics, right? So you still need to take a really good fundamental history. And that's going to show and tell you like, okay, patients have checked off some of these boxes: mechanical low back pain, refractory to physical therapy, conventional medical management. They have, imaging that's been done. So advanced imaging, which shows, multifidus atrophy. And if you can, you can see that on the picture here with this kind of fatty infiltration that's ongoing in the multifidi muscle here. And then, as Dr. O already mentioned, that they're not an appropriate surgical candidate. So they need to go through all those steps. Then they get to a point where, okay, we tried all these different things. Maybe they even did some interventional procedures, and they're sitting and seeing you for the first time. Well, somebody at some point in junction, in order to identify them as an appropriate candidate for this restorative neurostimulation, to Dr. O's point from the Reactiv8 study, you need to do you need to touch the patient. You need to do something, right? Idea of just looking at an MRI and then just saying, yes, this is going to work with all this confidence without doing any kind of physical examination, I think is a little foolish. So there are a few physical examination provocative maneuvers that can be done. This includes I'm going to kind of go back to this in a second, but this includes 3 different ones that we're going to show here, not on this slide, but the next. This one here is showing you, again, a different view of the checklist. I'm kind of focusing on the MRI component of this. Again, I wouldn't rely solely on imaging, but it can be very helpful to a new person or a new user of Reactiv8, or for introducing this idea to a patient, right? Because patients may have some difficulty understanding, like, okay, this muscle is not functional. they don't even know the anatomy of things. So if you take the time to kind of go over this and show them, okay, this is a normal multifidus on the very left-hand side. As you kind of go through these degenerative change and arthrogenic inhibition, eventually you can get to this right-sided picture, which is quite obvious, right? Where there's tons of fatty infiltration there, even more so than actual muscle itself. So these are these physical examination tests. Clinical cues are, it's interesting when you have a patient who has multifidus dysfunction and functional instability. It's not really anything like where patients are like having difficulty with like heavy lifting, pushing, pulling. A lot of times in my own office, it's the simple things. Patients have difficulty standing for a long period of time. They feel fatigue in their back and they need to change positions. They're constantly fidgeting. Or patients have difficulty leaning over the sink while they're brushing their teeth or washing the dishes. Or patients have difficulty even like with sitting for certain periods of time. So it's not anything that has to be like over the top where a patient needs to has pain with like lifting like heavy weights or 50 pounds or things like that. It can be very simple things, some activities of daily living as we call it. I'll run over these really quickly. So this is Kyle Kiesel, who has done a lot of fundamental research on multifidi, and he's showing you different tests that you can elicit in the office. One is a very simple one, multifidus toe touch test, where you have them bend forward towards their toes and you ask them to stand up straight. And what will happen with a patient who has multifidus dysfunction and resulting pain is that they'll use what we call a modified Gower's maneuver, where they'll kind of use their arms to slowly bring themselves back up to standing position, right? And you see this sometimes, right? Even when you're examining patients not for multifidus dysfunction. The prone instability test is one where you have the patient's legs over the side of the table. You apply PA pressure to the spinous processes from L1 to L5. You elicit a painful response at a specific area where there's more instability or there's instability. You then ask them to lift their legs off the ground. You create a pseudo kind of core stabilization, and then you repeat the test. And if that pain goes away, then you have a positive prone instability test, which would indicate that segment is unstable when at rest. Multifidus lift test is a really easy one to do, and you can even do it while you're sitting or standing in a chair. But in the appropriate way to do this is lying them prone in position with a pillow underneath their pelvis to relax their back muscles. But essentially, their arms are above their head, and what you do is you palpate the multifidi muscle on one side. You have them lift the contralateral arm or shoulder off the table in a posterior direction, and then you feel for the recruitment of the multifidus muscle on that side. So I do them on both sides for comparison's sake. So oftentimes you'll find them asymmetrically. If it doesn't recruit instantaneously, then I usually write in my note, this is a delayed recruitment, on the left side versus the right side. Or sometimes you'll feel no recruitment. There's like absolutely no contraction. There was a question on what you guys need to document as for, from the insurance side standpoint of things. And it's a very important question. I try to include as much information as I possibly can. I think about it like with sacroiliac joint, injections and infusion. You have to include a certain amount of provocative maneuvers. The more the more hardy your case is for that specific therapy. So absolutely would suggest that you document radiology findings, of course, history, and then of course a physical examination standpoint. At least if you can do at least two of these three, then you're covering all your bases. And this is again just showing you if you do all of those things, then the patient will have access to this particular therapy. So we're going to kind of move to the next section. But before we do that, there was a few more questions here.
Yeah, I think we're at the end of our time, so maybe we'll just take the questions and thank everyone.
Yeah, any or all of these tests required. I already answered that one here, Mike. The one thing I'll say about this diagram that you, I think, started off the kind of entire presentation over is that one thing we didn't say is all of these cases were actually taken from the original Reactiv8 study. And these were patients who were success stories. So as you can see here plotted on this graph, and I know it's kind of small, I apologize for that, but you can actually see provocatively how much of a reduction of VAS on each of these patients. And the one thing that the reason we point this out is that, as Mike says, these are people who walk into our doors every single day. And Mike says he sees this on a daily basis. Absolutely, as an interventional spine doctor, we see this. Modic end plate changes, multi-level degenerative disc disease, single-level degenerative disc disease, spondylolisthesis that are stable, amongst other things, facet arthropathy, facet arthrosis. So the interesting thing here is that it's not a single unicorn type of patient. I think that you can just identify on an MRI or single out, but it can be a multitude of different findings on MRI, but the presentation is pretty characteristic, right? Again, low back pain, and failing, all these other interventions. Yeah, I think at this point in time, we are kind of at that 6:30 mark, past it. So if anybody has any further questions, we can take them at this time. We'll get rid of these ones here.
And I think we're good. Slides, reminding them of our PSPS.
Yeah, this should be the last concluding slide here. These are just for Dr. I'll take this here. These are just upcoming APP webinars, one of which is also sponsored by Reactiv8. So if you have an APP within your organization, in your office, that wants to learn more about this as well, I think it's critically important, because APPs are expectedly doing more in the office and in the clinic. Make sure that they tune in and they can register on the PSPS website. We have call for abstracts, and also calls for research grant proposals. I apologize for speeding through these, but these are for our upcoming annual meeting, which you can register for here. It'll be in our backyard, Dr. O, October 3rd to 5th, first weekend of October at the Pendry. And
the weather will be perfect.
Absolutely. A lot less hot for sure. For those of you guys who stuck on the call, we appreciate your guys' time. We had a lot of registrants, but still had up almost 50 people on the call this evening. We appreciate you. If you're interested in obtaining more information about getting trained and certified in Reactiv8, this is kind of a pilot course that we've run this year, and this is the first time that Mainstay has agreed to do this. So really excited for how this goes and the outcome here. Because there are spots very limited, we're not gonna be able to take everybody who is on this webinar. So make sure you guys scan this QR code or reach out to us directly. Lakin or Trista are gonna be handling those requests. We'll then be going and looking at each of the applicants, vetting them through PSPS, and then invitations will be sent out prior to the actual meeting itself. Dr. O, any concluding thoughts?
No, please come join us at PSPS, get some more training on this Reactiv8 novel therapy for these chronic back pain patients, and come learn, come join us, and we look forward to seeing you at our PSPS annual event.
Thank you, everybody, for tuning in. We appreciate all the questions. As Dr. O said, we look forward to seeing you guys in October. Good night.
Good night. Thanks, Lakin.